Greetings, everyone. So nice to have you on this webinar, and it's my true delight to introduce Dr. Diane Fairclough, who has been an incredibly important member of the PCRC team from its inception. Dr. Fairclough is a professor of biostatistics and informatics at the University of Colorado School of Public Health. Her research interests include quality of life, missing data. She's a great person to talk to about missing data, by the way, and longitudinal studies. She's past president of the International Society for Quality of Life and the author of Design and Analysis of Quality of Life Studies in Clinical Trials. So needless to say, she's the right person to be giving this webinar. Dr. Fairclough, as I mentioned earlier, is an inaugural member of the PCRC, and she has served as both director and as lead statistician for the PCRC Data Informatics and Statistics Core. And in the last 5 years, she has been involved with several step wedge design studies. As you heard from Sarah, with her today is Aaron Shossi, who is ABD, all but defense, so close to PhD, and has been actively researching the technical issues around implementing step wedge designs. So we're so delighted to have you both on the webinar, and thank you so much for giving us this webinar today.
Okay, I really have to acknowledge that at least half of what I've learned, if not more, by being part of one study that's completed, two that are in progress, and a few more that have been proposed. At least half of it is because of what Erin's been doing and what we've learned through our her work and what we've been trying to understand. So for my outline is basically I'm going to quickly go over what a stepped wedge design is, and then basically as a result of this experience, I've developed kind of a checklist for feasibility, and it's a really good set of questions to ask when somebody approaches you, or if you're thinking about trying a stepped wedge design. And then at the very end, I'm going to give you some hints, different places where you can get tools that'll help you with the sample size and some of the issues around analysis. And then finally, we'll have questions that we'll try to answer. So the stepped wedge design is what I would refer to as a quasi-experimental design. It's a hybrid of a cluster randomized trial and a crossover trial. And the crossover is unidirectional. So what happens is within a cluster, so each row might be a cluster or a set of clusters in this little diagram to the side. The time at which a site goes from the control conditions to the intervention conditions is randomized, and it's staggered over time. And Cook and Campbell call this an experimentally staged introduction of basically a new intervention. So there's two versions of the stepped wedge design. One is cross-sectional, where enrollment of individuals happens continuously over time, and the treatment condition that they receive depends on which cluster they're in and what time period, and whether they're random, the cluster is randomized to cross over. Cohort is where all the individuals in the study all start together at the same time in the control condition, and the time at which they cross over to the new intervention is randomly determined. In the palliative care setting, a cohort design is almost unimaginable because our patients are not stable over time, and you'd want some kind of condition that you were studying that was pretty stable over time. And I honestly have not had any experience in the cohort design either. So everything else I'm going to say this morning is has to do with the cross-sectional design. Okay, so what are some of the reasons that we would choose a stepped wedge design? You know, there's a lot of settings where there's been a randomized controlled trial, a more classical trial, where we've established the efficacy of an intervention, but we really don't quite know about the effectiveness, or we're unsure how to implement it in a practice setting. And so a stepped wedge design has a lot of utility in these two settings. Part of this is because, you know, if we've shown the efficacy in a controlled setting of the intervention, we don't have equipoise anymore. And to some extent, we want all the sites to be able to participate in the implementation. It also may be easier to recruit sites if all the sites know that they're going to be exposed to the implementation, and you know, that they won't just be in the control arm. So there's also a efficiency in the design. You get smaller sample sizes than a traditional cluster randomized trial when you have a large interclass correlation. I'll talk about what that is exactly later, but and then sometimes we do it because we just can't logistically or financially introduce the intervention into all the units at once, that there's training that needs to be done, and it needs to be, you know, there's resources that are required to do that. It also is, you know, if we really want to study the implementation, you know, what strategies work as we introduce a certain kind of system change, and we need to study that. We need to find out, you know, how it's working. And then, as I mentioned before, it may help a little bit with recruitment of sites. So the statistical model, and the one that's, there's a number of them, but the one that's most classically used and is kind of the reference is the one that was proposed by Hussey and Hughes in 2007. And it has basically the YIJK is the observation that we do on the kth individual in the ith site and cluster, and at the jth time period. And so there's an overall mean, there's a random effect that allows us to model the between cluster variation, so differences between the sites. The beta J is a fixed effect that accounts for time trends. So if for some reason some famous politician gets diagnosed with something, or you know, some change in the CMS rules occur, that would be picked up by the beta J, assuming that it happened across all the clusters. It's assuming that whatever this time effect is happening is constant across all the clusters. And that's a fairly strong assumption, but it is the assumption that we're using. And then finally, what we're really trying to get at is this theta, which is our effective treatment. The Xij is basically an indicator. It's 0 when they're in the if someone's enrolled during one of the control phases, and one if they're in the intervention phase. And then there's the residual unexplained variation. That's the within cluster variation. The if you're doing a cluster randomized trial, the key issue in determining the power and the sample size is what we call the interclass correlation. It's basically how correlated are individuals within the same site compared to the differences between the different sites. You know, if there's something about the site where they're getting sicker patients, or there's something, you know, if we're there's just a lot of things that might make patients in the same practice a little bit more like each other than subjects in another practice. So this is oops, let's see, gotta push the right button here. Okay, so this is an example of the differences in power in a stepped wedge versus a cluster randomized trial. This particular example is with 6 sites where we have 6 different times that they might cross over, and 70 subjects per site. We're looking for an effect size of half a standard deviation and the normal alpha. And you can see with the cluster randomized trial, we've always known that as the correlation increases, our power will decrease because we're getting less information from each individual that within the cluster that we observe. But in the stepped wedge, it's almost flat. I mean, there is some variation, but it's very insensitive relative to the other setting. So, doesn't this sound like the best thing since sliced bread? Why would we not always do a stepped wedge design? And there are some good reasons. We had the stepped wedge trial that we've completed was a implementation of a decision aid for individuals with heart failure who weren't eligible for transplant or any other intervention to have a left ventricular assist device placed in there to assist their heart. And then work on other proposals have led me to develop this checklist for feasibility. It's something that I go through when somebody walks into my office thinking that they want to do a stepped wedge design. And so what are the challenges of the stepped wedge design? So some of them are administrative. You need to start all the sites at the same time. And that means coordinating all their IRBs. That one's kind of obvious, but we've got to think about how much challenging it would be to coordinate all the subcontracts, get them all on board at the same time, and then hiring study personnel at each site. So there's a fair amount of logistical challenges to do that. If you've run a multi-centered trial, you realize that this is a little bit not quite so easy. And the other issue is completing the study in more traditional designs. You know, if a site drops out, you know, that's not good, but it's not quite fatal. But if sites drop out before the end of the study, you're going to have fewer people in the intervention than you planned, and so you're going to, you know, it could be actually pretty challenging to the final analysis of the study. So you really have to have real commitment of all the sites to complete the study, and that's easier said than done. One of the other issues is accrual and selection bias. So you really want all sites being committed to similar constant levels of accrual during both the control and intervention phase of the trial. So that you get, it's they can't kind of lag along during the control phase and then all of a sudden get excited about the intervention, or they can't get fatigue over time and start having less patients during the intervention phase. But the other issue is the pool of potential participants large enough, or are they kind of continually renewing to avoid selection bias over time? So we, in the heart failure study, we thought, yeah, we have that under control. We have, the people that come in that are going to want, into the cardiac surgeon to have, consider the LVAD. That kind of renews over time. Well, we'll see that it wasn't quite so easy. The issue about, the other thing is if you're selecting from, let's say, clinics or something like that, and you're recruiting subjects when they come in for a visit, it's actually possible that the sicker patients, because they come in for more visits, will get recruited early in the study. And so there'll be more of those on the control arm. And if you're kind of exhausting that pool of participants and getting, waiting for patients that are doing better who have less frequent visits to come in later, then you're going to have different patients in your intervention group than your control group. So you really need to talk a lot about what the pool of potential participants are and how they're going to be recruited. So this happens to be our DECIDE trial. And if you look at the row that it's where it says total, what you see is that we did have a kind of declining number of patients over time across the enrollment periods. And that did result in fewer patients in the intervention group than the control group. The good news is we over-recruited, so we were still fine in that category. And the other thing is, and we didn't expect it, but fortunately, at least we measured these two variables, is we found that early on in the study, we were recruiting a higher proportion of inpatients than we were toward the end. The recruitment tended to shift toward the outpatients somewhat. And the other thing that was happening was at the very beginning, we had a higher proportion whose diagnosis was greater than 4 years, their initial diagnosis of heart failure from their decision to do this LVAD, and that declined over time. Now, by putting these into the analysis, we could control for that to some extent. But the question is always, were there unmeasured things that were changing over time? And it's basically unmeasured confounders that are a threat. And part of why I call this quasi-experimental, it does have doesn't have the protection that randomization at the individual level has. So there are threats to the validity and being able to assume that your control and intervention groups are equivalent. The next challenge is the crossover. And, if the duration of the intervention is short enough that you can avoid contamination during that crossover period, or if your intervention is such that when you do the crossover, you're not likely to contaminate the previously enrolled control patients, then you may be okay. In the LVAD trial, we had a single session intervention, so that in that setting, the duration was quite short and not likely to be a problem. If you had a 3-month intervention, you'd really have to ask a lot of questions about, what happens to the control patients who were enrolled at the very end of the control period when you do the crossover. So you have to think that through very carefully. And the next question is pretty much kind of the same idea, but is the duration of follow-up of the participants short enough to avoid contamination, or is the follow-up such that they're unlikely to experience contamination by the intervention? So you might have a pre-post design around that single session, and in that case, you're probably okay. If you have extended follow-up, it kind of depends on how much exposure those patients have during that follow-up period to the personnel who have now been trained to do the intervention. And then the part of this is, do you need an extended training or practice period to train personnel about the intervention, to get them up to speed in terms of being able to deliver the intervention? And that may be problematic in this design. So originally I thought, oh, well, we can just avoid contamination by having these washout or rollout periods inserted between the crossover between the controls and the interventions. It turns out that this type of incomplete design dramatically impacts the power. I'll show you that a little bit more, but it can be as bad as reducing your power by half, from 80% to 40%. And then the final question is, are there events or changes in policy that might result in time trends that occur in some sites but not in all the sites? And this is the hard one, because you don't always know that what's going to happen in the future, but it definitely is something to think about. So this is kind of the checklist, and I won't repeat it all, but there are administrative issues that you need to think about. There's the accrual and selection bias. There's the crossover issues, and then there's these internal, external time trends or events. And you can get these slides and you can pull the checklist up again. So going to analysis models, most common analysis model occurs when your unit of observation is actually the individual that you're doing the intervention with. And if your distributions are normal, binomial, Poisson, or even Cox, kind of survival type of time to event models, the Hussing-Hughes model will work. The only difference between the previous slide is there's some function of the observations. In the binomial, it's called the logit length, and so there's functions, and there's software that will handle these models. There's variations. Hemmings, and I have references at the back, summarize these. These are not all of theirs, but adding covariates is pretty straightforward. Repeated measures within an individual is also something that is relatively straightforward in most of the software. Where things get a little bit more complicated is when you assume that the treatment effect varies with time since the intervention was started, and when you try to look for cluster times time, or cluster times treatment, or treatment time interactions, sometimes your model, you won't be able to estimate all the parameters that you want to, depending on how you designed it. A simplification is actually to consider the differences between the fixed effects, between the clusters as fixed effects rather than random effects, and then it reduces to a general linear model. That's a fairly simple model to implement if you have some reason to believe that's true. That you also can use linear mixed models, so that the unit of observation can be summary data for each cluster at each time point. So it might be the number of children immunized, or the proportion. I don't know. There's other things that could happen where you have more. You observe things not at the individual level, but at the cluster and time period. That would be advantageous if getting consent, if you're looking at the implementation of some policy changes, or the way certain things are done more in practice. Some people do GE models. Generally, their outcome is binomial, and they have to specify a working covariance structure. Some endpoints may be problematic, particularly, at least for the methods that are available right now, where you really have proposed a non-parametric or semi-parametric model. We have one endpoint in our LVAD study where we're looking at a correlation between patient preference and their knowledge, and we proposed doing it using Kendall's tau, and there really isn't a way to implement this model in quite the way we talked about it with a non-parametric outcome like that. So now talking a little bit about power, like in all studies, the power is going to depend on the expected treatment effect. It's going to be influenced by the number of clusters. It's always better to have more. but sometimes you have to balance that by logistics and by the cost of more sites. The number of steps, I really didn't talk a lot about steps, but if you have one cluster crossing over at each step, that's the most efficient design, but sometimes it makes sense when you have a lot more clusters to maybe cross 2 or 3 over at a time. So you're doing the training for 2 or 3 sites, and then they cross over, you train 2 or 3 more sites, they cross over, and you continue to do that. Obviously, the number of participants is part of that calculation. You have the variance components. One is the how much variation there is basically within, between subjects. That's usually fairly well known, but then how much variation there is between the different sites or the different clusters, that's usually not available in any pilot data. And then there's design variations. The incomplete design that I showed you before, and some other variations. And then the standard sample size calculations that you can find easily assume that your cluster sizes are all the same and that your enrollment is constant over time. And that is in practice not likely to be true. So that's another thing that impacts the power. So talk just a bit about what are some of the optimum designs. If each cluster, so let's say we had 6 sites and we could roll them over each individually at a different time point. That's the diagram we have on the left-hand side. That has more power than if we roll them over 2 at a time. So we basically had 3 steps in our design. So you get more power when you can roll over more, but then sometimes that wouldn't be feasible if it takes more time and effort to do the training and implementing the intervention. The other issue is if you have, let's say we had 8 clusters. It's actually a little bit more powerful to have the maximum number of clusters in the first and last transition rather than having them spread out equally. So in the left-hand side, we have like 3 rolling over, then 1, 1, and then 3. In the second one, we have 2, 2, 2, and 2. This kind of idea also kind of extends to the size of the clusters. If the larger clusters roll over at the very beginning and at the very end, you get a little bit more power than if they're in the middle time periods. So this is a little hint into what we learned about these incomplete designs. I actually wrote the analysis plan for a grant, and I assumed that the power was basically a function of the total number in the control and the intervention, and that this rollover lag would have no impact on the power. Fortunately, it didn't get funded until Aaron did some of this work, and I realized that I was very naive about that. So if you look at the scenario where we have a complete design, like the design on the left-hand side, and we have a total of 840 subjects, and we basically have 20 individuals enrolled in each one of those time by site cells, and we don't have anybody in the rollover period. We have 80% power. If we changed it completely, where we inserted that rollover wait period, and so we have the same number in our intervention and our control, but we have 0 subjects down that diagonal. We drop our power down to 66%. If we can actually maybe have some partial enrollment in the that rollover period, so we have the same number total, 18 in the where there's zeros and X's, and 14 in that rollover. We're somewhere in between. We're almost back up to the 80%. But the striking thing is if we had an incomplete design, and we had no subjects accrued during that diagonal period, we would actually have to increase our enrollment from 840 to almost 1,200 subjects in our trial to get back close to that 80% power. So it's so that's why I'm glad that one particular grant didn't get funded before I realized what the impact of having no subjects down that diagonal thing. So just some tools for sample size estimations. PASS has a version, some of the newer versions allow you to test proportions, means, or Poisson, but it assumes equal cluster sizes and enrollment over time. Stata has a function called step wedge, and there's a reference to go to really get the details. And it'll handle some variants of the step wedge design. And then there's 3 different apps in R, and they're listed there, and you can get fairly, you know, if you really have an unusual design, you can handle them with some of these tools. So I need to mention that there's a few other investigators who have published on, to some extent, asking the question about whether to do a step wedge or not, and they discuss some of the limitations, and here, these are the references, but none of them have the nice little checklists that I have, and they don't all pick up all the issues that I've picked up in doing these. And then I have a whole bunch of references. This is a good place to start, but you can see that it's become a very popular design for, at least for statisticians, to talk about, and the number of trials has really increased a lot, particularly in settings like PCORI that are really interested in more pragmatic assessments of interventions. That's probably where when I talk to reviewers, they've seen the most proposals for this design. So thank you, and we now have lots of time for questions. And here's the strategy for looking at questions. And remind me where I see the questions.
So thank you so much for your talk. For anyone who has questions, if you put your cursor down in the Q&A, down to the bottom of your screen in Q&A, you can type in your questions. And Diane, I think you will move your cursor to the top of your screen where I think it says more options.
Here we go.
There you go. So we'll give you all a couple of minutes to submit questions, and if we'll be able to ask some now. We have a fair amount of time. We also could do some follow-up over email after the webinar is over too. For anyone who would be interested in downloading these slides, we do have them on our website. Right now they're listed at the very top of the page, but we will soon be moving those down to previously recorded webinars. So if you'd like to re-listen to any part of this webinar or download the slides, you can go to the Investigator Development page, Webinars. Okay, the first question that has come in is, can you speak a little bit more about cohort design?
So again, the cohort design would be when all the individuals start under the control or usual care setting, and the time at which they cross over differs across the different subjects. And the part of the challenge, and I'm going to be more specific to the palliative care setting, is that you would, for this design to work, you would want to be able to observe all of the patients over the entire period that you propose to follow them. So, you know, if your duration of your study is 2 years and you're crossing over, even a year, and you're crossing over people at different times in that year, maybe let's say at 3, 6, and 9 months, if your patients are either unable to complete the assessments or passing away, then you're you have all this missing data in the intervention phase. So, but you know, and the other issue is that they're likely to be progressively getting worse. So it's you're going to kind of be comparing apples and oranges. You know, if you were in a setting and looking at something like chronic migraines or some other chronic disease that's pretty stable over time, then this might be a great design, and you know, the time that, and there's some time issue that you're interested in looking at. it does have the advantage of you're doing within subject comparisons, and that is definitely more efficient.
Thank you, Diane. The next question is, would you please talk about the statistical implications of having unequal numbers of clusters per step? For example, say you have 12 clusters, but only time for 8 steps, and let's assume you can't make the steps shorter.
Shorter. There, Erin, do you want to grab that one? Is she on mute?
I was on mute. Can you hear me now?
Yes, we
Erin,
can
do
hear
you want
you.
to grab that one?
Okay. Sure. So Diane brought this up a little bit, that the optimal power for stepped wedge occurs when you can roll out one cluster at its own time. But it really depends on some of your other factors, how much power you're really losing if you have to go to a setting where you roll over, for example, 2 clusters at a time. And there's a really good example in the paper by Hussey and Hughes where they compare power curves for 24 clusters, where they vary the number of measurement time periods, where they go from 3 clusters randomized at each time to 12 clusters randomized at each time. And you can get drops in power from, that are about 10% with each more additional cluster that you add to the rollout period, but it might not be that much depending on some of the other factors in your design.
You probably would want, if you only had time for 8 steps, you probably have a couple more in the very first one and a couple more in the very last one, and balance it that way. That would probably be your optimal design.
Thank you. Another question, is there an optimal number of clusters in a step wedge design?
Not really. Having smaller numbers of clusters is a little bit more risky. It's kind of the same issue as, smaller numbers of subjects. The more subjects you have, the more power you're likely to have, and the more likely you are to be balancing any unmeasured confounders. But I would be extremely reluctant to go under 6, and I would be much, much more comfortable with 12 or more. Really happy to get 20. So that's, it's kind of it's a balancing. More is always better in terms of the statistics, both the power and the likelihood of having things balanced. But there's always the feasibility, the cost of doing multiple training sessions, and the cost of more sites. Most of our grants have a limited budget, and the number of sites that we can afford is often our most limiting factor.
Thank you, Diane. One other person asked, could you please give an example of an incomplete design?
So the incomplete design would be when during your crossover, you have a period of time in which you are not enrolling individuals. That would be the most classic incomplete design. Erin, can you think of another example?
Yeah, to speak about it a little bit more specifically, to give a concrete example, there's a paper by Hughes et al. That came out a few years ago, and the one that they like to bring up where an incomplete design is needed is where there's an intervention that is given to pregnant women, and they need to, when the site rolls over to the intervention period, they need to have a period of time where they're not delivering the intervention at all to the site, and they're not enrolling any new patients, in order to give the pregnant women that had been enrolled during the control period time to deliver, so that there wouldn't be any possibility of the control group pregnant women to be exposed to the intervention until they had all delivered their baby. So they need to have a period of time where there's just absolutely no intervention being delivered at the site.
Thank you. All right, one more question came in. When you are reviewing grants with a stepped wedge design, are there any considerations aside from power, number of clusters, number of steps, and the checklist items that absolutely must be addressed?
I probably would say I'd actually kind of dig down deeper on the logistics of the crossover. That's on my checklist, but I would really want to dig down and know how, how they're going to follow the patients, how they're going to deliver the interventions so that they don't have contamination during that crossover. That would be the big one for me to see if they really understood what they were getting into.
Okay, thank you. If we don't have any other questions, we can wrap up. If any questions do arise, you're welcome to send an email to pcrc@ucdenver.edu, and we would be happy to funnel those questions to Diane and to Aaron. And we would like to remind you to keep an eye out for the evaluation that we send after each webinar that allows us to know how we can improve and how we can make sure we are adding all topics that you would find useful for your investigator development, that we can plan those into future webinars. And you'll see that there's a couple more webinars that we have scheduled already, and you're welcome to visit our website to register. So thank you so much, Diane and Aaron, for presenting today, and we look forward to seeing all of you on future webinars.
You're welcome.
Goodbye, everyone.